Hello and good afternoon, everyone. Thank you so much for joining us. Today, we're bringing you another virtual event from the Alumni Association. These are our upfront talks. They're virtual talks with experts. If you've not attended one before, my name is Scott Thompson. I am Associate Director for Engagement at the Alumni Office at Ole Miss. And I have the pleasure of working with a couple of different schools on campus, one of which is our School of Pharmacy. And today I'm very happy to present to you some of our experts from the school. It's Team Meagen. We've got Doctors Meagan Brown and Meagan Rosenthal. And I'm going to give a brief introduction. And Meagan and Meagan, I'm sorry, I'm probably not going to hit all of your accomplishments or accolades, but I'm going to give as brief so we can go ahead and get into our program. Dr. Brown, she comes to us with education from the University of Mississippi School of Pharmacy and Xavier University in Louisiana. She's a clinical assistant professor of pharmacy practice, and her research interests include cardiometabolic diseases, community-based research, community pharmacy, rural health, health disparities, and the scholarship of teaching and learning. And Dr. Rosenthal, she brings a slew of degrees from the University of Alberta, and with her bachelor's, master's, and PhD. And she's an associate professor of pharmacy administration, as well as a research associate professor in our Research Institute of Pharmaceutical Sciences. Her general research interests include community pharmacy practice advancement, implementation science, and patient-centered research. She's also interested in improving diabetes self-management and developing patient-centered weight management programs. Now, as y'all can tell, I went off of our website for our faculty directory, and I left out just tons of things about you. So if you want to talk a little bit more about your research or some of the things that you've done along the way in your career, please feel free to elaborate. But I'm very happy to turn this program over to you so that we can learn more about our population health in rural Mississippi. Thank you so much.
Thank you, Scott, for that introduction. I think you shared more than enough. That's enough to get us started. All right, I think I've got it together. So Dr. Rosenthal and I are excited to talk with you all today about population and rural health in Mississippi, and specifically give you guys a little bit of an overview of our course. And throughout this presentation, what we really hope to do is give you guys an idea of the course description and list of speakers that we have slated for this semester's launch of our P3 course, PHCY 606, as well as talk a little bit about population health and rural spaces for the purposes of this class, as well as defining health equity, what health inequities look like in Mississippi and the US, which kind of leads us into the major project for our students during this course, which I think you guys will find exciting, and also talk a little bit about some additional resources and opportunities on how you can get involved in the area of population and rural health if interested. So the first thing we want to cover is really just about our course description, and just knowing that the real purpose of this class is to expose our pharmacy students to population health and just what that means, especially from a pharmacist perspective. We talk about the rural burden of disease, including, the health profile, social determinants of rural health, and some strategies to improve rural population health. I think this is just really important because considering where we are, we would be remiss if we ignored the setting in which we live, and understanding that a lot of our students are Mississippi born and bred, or are going to be serving the Mississippi community either through their rotations or their future careers and staying in Mississippi. We wanted to be sure that we equip them with the tools that they need to address some specific issues or concerns or challenges that we have with patients who live specifically in our rural areas. The focus of our course is also just, talking about their role in health outcomes, as well as identifying some patterns of health determinants and talking about how policies and interventions, correlate with some of the things that we see. And so understanding that it's bigger than just a disease state, it's bigger than, what we see in this particular patient and how they present, but knowing that there are policies and systems and institutions that are in place that can also contribute to the person's ability to be well. So these are the topics that we've been working on this course for quite, I feel like a long time. I was looking at some of our drafts in our old file from 2018, and I said, gosh, that's been 3 years. I can't believe it. But really brainstorming, we had an excellent team of folks really helping to develop this course, and contributions from all departments in our School of Pharmacy. And so we were able to really come up with some, I guess, more global topics that we felt would be very important for our students to hit on. And so they're listed on this slide. I won't read them all to you, but just to note that we, of course, started with some basic understanding about population and rural health, addressing health inequities, cultural competence, some major determinants of health. We talk about global health inequity as well as global rural health and what that looks like. We talk about the social and economic issues in communities that impact health, as well as health service provisions, remote health services, which has been huge and very timely in the time, of course, considering the pandemic, as well as agricultural health and safety, which is what they're covering this week. And then next week, we'll explore climate and weather as far as environmental health, emergency preparedness, respiratory disease, and then end on global endemics, and that stuff will be covered by our Department of Health folks, which is really great. And that leads me to our speaker list, which we have highlighted, some of the folks who have contributed to our class, and I see some of them on our call today. So thank you for joining us. But we would be remiss if we did not tap into the talent that we have on faculty, as well as the faculty who contribute in other departments. So as you can see from UMMC, we've had Dr. Penman, who's in the School of Population Health. We have some Department of Health residents and pharmacists who joined us to talk about their role and in public health and rural health, as well as tapping into some of our residents who've contributed to the work that we've done, and sociology and the anthropology department as well, who've contributed to some of this work, Dr. Ross. So there's lots of folks on here who we have just really tapped into to provide some of their expertise, as well as, where this these topics have fallen in their research interest. And so it was a great opportunity for us to recruit some really talented folks to contribute to this course. And I think that the students are excited because it certainly gives them a break from Dr. Rosenthal and I, even though, we try and be as entertaining as we can, but I certainly think it's nice to have some other faces, some fresh faces contribute, as well as share their knowledge with us. So I'm going to turn it over to Megan.
Thank you, Megan, for that intro. And I think that it's important to note, as part of the design of this class, that we did it in a very thoughtful and careful way in terms of integrating and introducing some of these topics to our students, and really the focus on the broad implications of rural health around the world, and helping our students understand that, while we do face some very particular situations here in Mississippi, the rural health problems are a global issue, and that we really have an opportunity to learn from what other communities and spaces around the world are doing, and how we can improve the health of our community folks who are local to us here in Mississippi. And so what we're going to talk about next here is really defining kind of population health. And these next few slides that we are going to look over here have been pulled actually from that really great list of speakers who have already contributed to our class. We didn't think it would be, it seems silly to reinvent the wheel and put forward new slides that had already been in existence. And so this next few slides come from Dr. Penman's lecture, which he gave at the beginning of the semester, and really helped us set the stage for how we, as part of this class, are going to be approaching population health, and also defining kind of rural spaces and what that means for our class. Next slide, please. So the definition of population health that we've really been working from is the idea of understanding health outcomes of a group of individuals, including the distribution of health outcomes within that group. And so population health is not just about overall health of a population, but also includes the distribution of health, or so how healthy all groups of people within that population actually are, not just whether or not they have obtained, some folks have attained health and others have not. Overall health could be quite high if the majority of the population is relatively healthy, which is something that we actually see a lot of here in the United States. For the most part, folks are relatively healthy. However, there is small pockets of people who suffer disproportionately from negative health burden. So population health research is really fundamentally concerned about the interactions between multiple health determinants to produce health outcomes. And so the unique thing I think that we need to think about when we're talking about population health is it's not just focused on those clinical outcomes, right? We're really also taking into consideration all of those other factors that contribute to whether or not you can live the best possible version of your life that you can in terms of your health. And the goal of population health is to approach, or of a population health approach, is to improve the overall health of the entire population, and in so doing, reduce health disparities or differences between the groups who are members of that population. Next slide, please. So there are three kind of overarching concepts. I'm not going to read this slide because I know there's a lot of stuff on here, but three overarching kind of central concepts around the development of effective population-based health prevention strategies. And that's a really fundamental perspective that we're taking in this class. So first, disease risk is currently conceived of as a continuum rather than a dichotomy. And so this is really focusing on this idea that you are not just healthy or not healthy, you can have varying degrees of health along this across this larger continuum or spectrum. Second, most often only a small percentage of a population is at the extremes of either very high or very low health. Forgive me, getting a lot of text in the background here. Third is this idea that an individual's risk of illness cannot be considered in isolation from disease risk of the population to which he or she belongs. And so this is really this idea that we are connected to each other in ways that we may not always appreciate as individuals. And that this connection really drives our capacity to be healthy or to achieve health or not achieve health. And we're going to get into this in a little bit more detail a little bit later, but just by way of an example, if you are someone who lives in a community like one of our many rural communities here in Mississippi that does not have access to a regular grocery store, may only be able to get their food from the local Dollar General that doesn't typically stock things like fresh fruits and vegetables, that location where you live impacts whether or not you are going to be as healthy as someone who let's say lives here in Oxford and has the opportunity to avail themselves of at least 4 grocery stores that I can think of off the top of my head, right? So our physical circumstances, our environment really impacts our ability to engage in healthy eating activities, let's say, for example. Next slide, please. So alongside of this kind of setting the foundation around our understanding of population health, it's also really important for us to understand kind of what it means to be rural. And this is important because it has implications for how we interact with people and how we understand differences between urban and rural populations. So one of the definitions that we've applied in this class is really looking at the definition provided by the US Census Bureau. And this definition is developed and basically works in 3 main areas. So urbanized areas or UAs are areas where there are more than 50,000 people. And so this is a very crude definition, but thinking about like large cities or large metropolitan areas. Urban clusters are those spaces that have at least 200 or 2,500 people, but less than 50,000 people. And then rural, according to the census, isn't actually defined, but you can kind of the ad hoc definition are for spaces that are less than 2,500 people. So under this definition, about 21% of the US population in 2000 was actually considered to be rural, but more than 95% of the land area was classified as rural. In the 2010 census, this equated to be about 59.5 million people, or about 19.3% of the population is rural. And so you can see that we're actually facing some not insignificant declines in the population of people who are considered to be living in a rural environment. And this has really important implications, not just for the folks that are living there, but how we, in terms of policy and creation of laws, figure out how to serve those particular populations when there are those significant population declines. Next slide, please. So this is a representation here of kind of a little bit of a breakdown around urban and rural spaces in the United States. And I know all of you will know where we land on in Mississippi there, but I think it's important to note that we are largely kind of within that dark green spectrum of colors, which indicates that a very significant portion of our state is actually counted as being a rural space. And as all of you know that are on this call that work in some of our smaller communities around the state, you have front row seats to what this means for taking care of your particular patient population. Next slide. So I know this is a bit of a preaching to the choir, but we did present this information to our students because, you know, it's important for those of them who have come from more urban settings or maybe from out of this state to understand why people would choose to live in a rural setting, even though that, you know, you don't have ready access to Walmart or Target or whatever the case may be. And so a lot of these reasons involve things like lower cost of living, slower pace of life, access to big open spaces, rural areas also afford more privacy. And all of these factors in combination also lead us to understanding the culture of the people who live in rural spaces as being quite distinct and different from the culture of folks who live in urban spaces, and how we interact with them and how we go about providing care to those populations of people should be in part determined by an appreciation of those cultural differences. I see a hand raised. If you want to unmute yourself, go ahead.
Hello. Sorry, just a quick question.
Mhm.
So we have the urban area, and where do the suburbs fall? So I'm just a bit confused. So how are we classifying the suburbs according to this?
So you bring up a really great point. So this is the definition of urban rural that I provided is just actually one of the many, many definitions of urban, rural, and suburban that are applied across this country. And that has important implications for how we understand each of those different populations of people. So according to the Census Bureau, this would be the suburbs that you're referring to would either be part of urban areas or, and I can't remember the semi-urban areas, that kind of in-between group where they're sitting between 2,500 and less than 50,000. Now we know that the culture of people living in suburban areas is probably a little bit different than folks who are living in large urban centers, like let's say Chicago, for the city of Chicago proper, for example. And so thank you for pointing out kind of the complexity around those definitions and what that implication might be for understanding those various different subpopulations in the country. There are, I can think of off the top of my head, at least 3 different definitions for urban, rural, suburban population understanding that have been used by various government organizations. And each of those different applications of those definitions matter in really significant and important ways for how resources are allocated or not allocated to these various communities. So thank you for that question.
Yes, and
Mhm.
you finished, Megan? I'm sorry.
No, go ahead. No, please go ahead.
Okay. And I think that also leads us with the complexity around definitions, as you said, bringing that up is a good point, because it definitely leads us to what we'll talk about next, which is health equity and how the different definitions certainly contribute to the ability and the access of resources that are available based on who is defining what, right? So I think we would also be remiss if we did not share this image, which is something I think our students have now seen maybe 10 times, but talking about equality versus equity, because it is an important distinction that should be discussed, and especially in the scholarship of teaching and learning, or teaching and learning with the students, we want to be able to point out that equality just simply suggests that we provide every person with the same experience. And as you can see from this picture, equity would be versus equity, which would be working to overcome some of the historical legacy of discrimination, marginalization, and underinvestment that disadvantages specific groups of people. And sometimes I think probably the more top of mind subject when we think about specific groups of people would be around race. But as you can see in this picture, it also can be related to ability and other things, gender equality or versus equity. So there's lots that contribute to that definition. And so equity just requires providing support tailored to the specific needs of an individual. And, truly being equitable is a goal that I think that we are now shifting our terminology toward, because equality does not necessarily mean equity. And so when we think about health equity, this is a definition from the Healthy People and Disparities website, but just talking about the attainment of the highest level of health for all people. And so that happens when we are valuing everyone equally and focusing on the efforts to address unavoidable or avoidable inequalities. And like I mentioned, some of the historical and contemporary injustices that have exist based on the systems that have been built and institutions that we currently have in place. Additionally, the Robert Wood Johnson Foundation defines health equity as, a means that everyone has a fair and just opportunity to be as healthy as possible. And so that requires removing obstacles to health, such as poverty, discrimination, and just, thinking about all the other consequences of these things, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. And so there's a lot that goes into that. And obviously, I think that's a big, bite to chew, just because there's so much that it's so loaded. It's a loaded definition. But this is also, I think, just very important to acknowledge that there's so much that goes into what health equity looks like, but realizing what role that pharmacists play in being able to provide or contribute to the ability of making health equity a right and not something that's just a privilege for some. And so there are things that contribute to health equity. I think our students have also probably seen this slide 10 times, but I definitely think it's important for us to talk about different steps that help us achieve health equity. And so one of those things is identifying important health disparities. And so many disparities in health are rooted in some of these inequities. And the opportunities and resources that that are needed to be as healthy as possible. And so the social determinants of health include some of the stuff that you see on this slide. This is from the Kaiser Foundation, but really thinking about the economic stability and what that looks like for our individual communities. The ability for patients to be employed based on their location, the average income of an area, their expenses, debt, medical bills, and support. And then thinking about the neighborhood and physical environment. This often comes up, and I'm in Yazoo City, Mississippi, if anybody is familiar or knows about Yazoo City, but a totally only, I believe, 36 miles from Jackson, but a totally different experience as far as what our patients have access to. When we talk about housing, transportation, safety, parks and playgrounds, walkability, these are things that often our patients struggle with when we are recommending to our patients with diabetes to take a walk in the local park. There really is only one walking track at the high school, so just thinking about their ability to have access to that, or the safety of their roads, or stability of their roads, to be able to to suggest such things that we're teaching our students. Of course, education plays a part in that, and so looking at literacy and language, and specifically health literacy, is something we cover. And then food and hunger, access to healthy options. And so this is something we're covering this week in our course with our students. And so I think it's really exciting to be able to talk about that, because oftentimes we teach them the right things to say and recommend and do. But as Meagan mentioned a few minutes ago, thinking about what's available in Oxford versus what's available maybe in Yazoo City, where we only have 2 grocery stores, one of which is fairly expensive, and then there's a Walmart. And so having to consider what options are available to our patients, as well as where the fresh foods and vegetables may or may not be. And then community and social context is hugely important. And as we know, as I would assume that some of us are being a part of the Southern culture, realizing that social integration and the support systems may differ depending on where you live. I think the pandemic has also brought about a huge disparity as it relates to being able to socially integrate, especially for our elderly populations, and their level of community engagement that they may experience now versus the pandemic, during the pandemic. As well as discrimination and stress that may play a part in their ability to seek access to the resources they may need to be their most healthy self. And then lastly, the healthcare system. So thinking about the coverage, availability of providers. And this is also something that we were talking about in our course this week, which I thought was really interesting at looking at in the more rural areas where there are provider availability and accessibility, as well as linguistic and cultural competency, which is something we cover in its entirety in a week as well. And then the quality of care that's provided to patients. So this is just one piece of, the things that contribute to achieving health equity. In addition to that, I just wanted to highlight that changing and implementing policies, laws, systems, environments, and practice to reduce inequities in the opportunities and resources needed to be as healthy as possible. Evaluating and monitoring efforts, short and long-term measures, and then reassessing strategies in light of process and outcomes, and planning next steps are some things that we can do to help achieve health equity. So did we have a question?
So in terms of the rural demographic, I'm just curious to know what role does religion play in the population, the health population? Can you shed some light on that?
I will take a stab, and then Megan, you can take a stab as well. But I do know that as it relates to different religions, and how that looks as far as health is concerned, that there have been a lot of efforts and funding related to faith-based efforts, and so targeting health from a faith-based perspective. As you know, the South is heavy in the Bible Belt, and there are certainly a large number of Christian or Catholic populations in this area. And I would say that certainly that's been a way that health efforts, specifically in marginalized or underrepresented minority communities, health efforts have been targeted in faith-based operations. For example, using churches to be an opportunity to deploy different health efforts, because there is a mistrust that may be related to the healthcare system that has played a role in patients either not accessing care or not being comfortable accessing certain pieces of care because of that. So certainly there has been some literature as well as funding that has gone into faith-based efforts in trying to, I guess, remedy some of the disparities that exist by targeting patients through their faith-based organizations. I'm not familiar as much with different religions and whether or not certain populations are healthier. To be honest, I've worked in this community for about 10 years, and there's mostly I would say most of the patients that I interact with are Christian or either Jehovah Witness, the Jehovah Witness group. And so that is probably my limited experience. But I would say that because I work in a underserved area, that there is no difference. But that's just from my own personal experience. And I would be interested to see the literature on that as well. So Meagan, do you know, or you have anything else?
I can't think of any names of studies off the top of my head. I don't think that there has been a lot of work done looking at, specifically, like you said, Meagan, around kind of understanding potential health differences based solely on religious beliefs or religious practice. And I also agree that the majority of the interventions that have been worked through in the Southeast have definitely focused on leveraging the community networks that religious organization churches and groups like that have in terms of kind of spreading the good word of improving health and improving diet and improving all of those kinds of things. That's been much more my experience as well.
And my question is leading to why isn't there more incorporation of certain faith-based initiatives other than the community, from the Christian communities? And at some point, I think the ethnic demographic is also changing in the Deep South.
Mm-hmm. I think there's certainly a lot of opportunity there, and we're gonna talk about this later in our presentation today for chances for folks who are interested in engaging in some of this work after our talk today. I'd certainly be interested in investigating those differences further and seeing if there are opportunities to leverage the perspective that you're talking about in improving the health of all folks who live here in Mississippi and in the Southeast more generally. So yeah, absolutely. Thank you for that. So in the next few slides, we're going to talk a little bit more specifically about health inequities and just identify, and I'm well aware of the fact that the majority of you all on this call are probably have already seen this. And so we're going to hit, I'll plan to hit some of the highlights, but then also finish up with in time for more discussion and more conversation, because we do appreciate the questions that have come in so far and want to hear more from the rest of you as well. Next slide, please. So here's just a little bit of background about the people who live here in Mississippi right now. So we have almost 3 million residents in the state. About 22% of our residents here live below the poverty level. And that's in comparison to about 14% of the United States population who are below the poverty level. Also, about 20% of our population has less than a high school education, and the median household income of residents of the state is about $38,000. So that sets the stage for some of what we're going to be talking about here in understanding those differences in health outcomes based on some of this demographic and background information. Next slide, please. So looking at this slide here, this is talking about the life expectancy in the US by different racial and ethnic backgrounds. And as you can see here, that there are some not insignificant differences based on racial background, looking at distinctions between white men and women compared to Black and male and female counterparts. And we're also seeing some not insignificant differences in terms of life expectancy between racial or between ethnic minorities, looking specifically at Hispanic and Latino populations as well. And it is important to note that those differences are statistically significant, not just differences by numbers themselves. So these are meaningful differences that we're talking about here. Next slide, please. So this one is, this slide is talking specifically about infant mortality rates, which is an important measure of a health, kind of broader health of a community. And again, we're seeing significant and important differences in terms of racial and ethnic background in these numbers. And I think it bears mentioning that the infant mortality rate in Mississippi is significantly higher than it is in the United States more generally. I think we get to that on the next slide. Yeah, so if you look at the infant mortality rate of Mississippi, we are sitting somewhere between 9 and 11%, and we're nestled nicely in with a good chunk of the rest of the Southeast. And these differences are important for understanding, like I said, the general health of the bulk of the population. Next slide, please. And so as you can see here, we also have some issues with preterm births here in Mississippi. And you can see that there are some differences, significant differences based on kind of the situation of the mom having the babies. And again, these are incredibly important and are staggering if you compare them to the rest of the country, but then also to other areas around the world that we consider to be potentially less developed than we are here in the United States. Next slide, please. So as one of our question askers already pointed out, we do have a significant issue with obesity in the United States. And it's in particular, this slide is talking about childhood obesity and differences between some of the subpopulations of note. And this, we know that based on the recent data and literature that's been published around childhood obesity, that the opportunity that children have to lose weight and maintain that weight loss over their lifetime sets them up in really unfortunate ways for dealing with lots of chronic conditions later in life. And it makes it incredibly difficult for them to maintain that loss over their life period. Next slide, please. So moving further into some of the information and data that we have around chronic conditions, you can see here are some differences in terms of high blood pressure rates amongst the different subpopulations, and whether or not folks are taking any medication or are being prescribed any medication for that. So again, we are seeing significant differences between our Black or African American populations and our Caucasian or Hispanic populations in terms of rates of hypertension over time. It is worth noting that we are seeing some declines in those numbers, but we have yet to see them kind of merge into a singular point in time. Next slide, please. We are also seeing a similar situation with high cholesterol and of course with diabetes as well. Mississippi has one of the highest, if not the highest. We flip-flop between Louisiana and West Virginia in terms of who is the highest rate of diabetes in the country. But we know that around over 370,000 people who live in Mississippi are currently diagnosed with diabetes. We also estimate around 80,000 of those folks who have diabetes but might not know they have diabetes. And there is an even more significant population of people who will be in that kind of pre-diabetes category who have yet to develop full-blown diabetes but are certainly headed in that direction. We also know that diabetes is an incredibly expensive condition to treat if not managed appropriately, and can cost the medical system, according to 2012 estimates, up to $2.6 billion annually, which is a significant amount of money, an unfathomable amount of money, really, if you think about it. And one of the reasons that I spend a lot of my time working in the area of diabetes self-management is that it is, like many other chronic conditions, one that we can manage effectively. And if we can empower our patient populations to do that work themselves, have the opportunity to really mitigate and in some instances reverse the diagnosis itself, we just need to find a better way of helping our patients to accomplish that objective. Next slide, please. This is just another perspective on the blood pressure burden here in Mississippi. As you can see, we are around nearly 40% of our Mississippi population has high blood pressure already, and that's in comparison to about 30% of the American population more generally. So we have a much more significant burden around that, which makes sense in many ways, because we also have high rates of obesity and diabetes as well, and those things tend to go hand in hand. Next slide, please. Same thing goes for high cholesterol. We are significantly higher than the American population more generally. We sit about 42% of Mississippians have high cholesterol in comparison to about 40% of the general American population. Next slide, please. So bringing it to a more recent example, we also see disparities or differences in terms of outcomes and rates of exposure based in relation to the COVID pandemic itself. And so we are seeing far higher numbers of American Indian or Alaska Native, Black or African American, and Hispanic people in having diagnoses of COVID, in being hospitalized as a consequence of getting COVID, and unfortunately also of dying of the condition. And this is really reflective of many of the other disparities that we've already identified and those social determinants of health that Meagan covered in some of the previous slides.
What would an Arab person be classified as according to these categories?
I think it's a good question. I don't know where people of Arab descent may have landed in this breakdown from the CDC. We could certainly look into it and see where they may have been classified, but I would not want to hazard a guess right now and misspeak on that question.
This is from the CDC. And so this data is source level that was pulled at the bottom. There are the sources right there. And so I normally the COVID cases and information is reported from departments of health, and the CDC are taking all the data from the departments of health across the US. I don't have the answer to where Arab or Persian populations may fall. And like Meagan, I'd be hesitant to hazard a guess onto what category they, that they have classified for
I
sure.
mean,
And
so how are they classifying this? I'm sure there are.
again, I can't answer that because I don't work for the CDC. However, there are differences between race and ethnicity. And usually depending on, I guess, where you would define, and I think that depends on where the Department of Health is defining those categories, because there is a difference, like you mentioned, between race and ethnicity, right? So there's certainly a distinction that has to be made. And depending on what the departments of health are putting out for people to identify as, that certainly is something that they have to choose based on what is available. And I can't answer what is available because I don't know what this, how the CDC utilize or define that information. The other thing is race is a social construct. And so, that is certainly something that I believe people will choose to identify as. And so that's something that we, cannot define for each individual person. So I understand your question. There are definitely certain skin tones, and I don't think this is based necessarily on skin tone, but just how people choose to identify themselves based on what was available. And I do agree that there is certainly an issue in making sure that demographics are inclusive. We've talked a little bit about, I personally have an interest in implicit bias and bias related training and healthcare related bias. And so I think that there is certainly an issue in how we present information to patients so that they can properly identify themselves, and how they define who they are. So I can't really answer the question, but I do know that this is not necessarily based on skin tone, because as you mentioned, there are, Black Persian people, there might be lighter skinned Persian people. I don't know how the CDC allowed people to identify them based on the demographics that were provided. So I hope that helps. Okay, so we'll talk a little bit about of how this comes together for our pharmacy students, and kind of circling back to our course, and thinking about how that looks for them. And I think this is a great time for us to highlight just the major project and work that the students do over the semester. And so in the beginning, we give the students a project description to talk about, the work that they will do over the course of time, and hoping that our subjects that we present and the information that we present gives them an opportunity to learn a little bit more about the social and economic status of the community that they're choosing to observe. And that really helps them build an intervention, a community intervention to address a problem that they identify. So as it says here, the purpose is just working with a community. So our students choose a community that they want to work with, and to identify a population health problem. And then we have them create an intervention-based project to address the problem. And so we give them a project description in the beginning, and hope that they pick a real world situation and an issue that they can identify based on what they know and can learn and research about a community. And then the project really encompasses two different parts. There's a written part, and then there's an oral presentation that the students will give at the end of the semester. And so the project components are listed here. And so a lot of the work that they have been doing up to this point is providing drafts and milestones about the information that they learned about their community. So they talk about the community itself, and then they talk about the intervention that they would like to provide, as well as provide some methodology on what they are going to do in their community-based intervention. And then they provide us with timelines as well to tell us how they plan on implementing this community-based intervention to best help the community, and based on what they have found out. here's a list of a few of the project examples that they have been working through. Our students are brilliant. They have been coming up with some really amazing interventions and things that they really want to get done. And it's so exciting. I think if we were not in COVID times, we would invite folks from these communities if they were close enough. And we still may do that to join us. I guess virtual also offers an opportunity for us to invite people from said communities so they can join us to hear a little bit more about what our students, have to offer, or things that they would consider offering for the communities if given the chance. I also think that these projects lend themselves to opportunities for students to go out and really work through this. We encourage them to pick communities that they're familiar with. So a lot of them pick their hometowns or places where they grew up near, or where they have families. So they're a little bit more familiar with the work and things that happen in those communities. So things that they touched on include health literacy, food accessibility, telehealth, to improve hypertension management and heart disease outcomes. I love that. Addressing substance use disorder, mental health concerns in specific populations. So just some really great things that they are observing in communities and how to, address this from a population health lens.
So with that, I think this is the segue to opportunities for everyone to be involved in this work. We have really focused a lot of our attention around the major project on the students doing work that's applicable in the real world. Because as we showed in that larger set of data slides, the health inequities and health disparities that we experience here in Mississippi have real world implications for actual people. And one of the major drivers of the work that we do in the School of Pharmacy is to improve the health outcomes of the patient populations for which we are responsible. And so if you are interested in being part of the presentations or coming in to listen to some of the student presentations, please let Dr. Brown or I know. We would be more than happy to share the link to the Zoom calls when we have those presentations. Or if you have a population health concern or a project that you would like to be implemented in your pharmacy, there's also an opportunity for you to be involved in that way too. We may have students who have already developed a project that we can plug and play and get you off rolling right away. Or we can also use some of the resources that we have available to us at the School of Pharmacy here at the university to help you work out a project that would be that would meet the needs that you're trying to accomplish as well. And finally, I am privileged to be part of a practice-based research network that spans across 5 states here in the southeast of the country that is ideally working specifically with rural community pharmacies to address some of these specific concerns that we've talked about already. And so if you are interested in being involved in rural CP, the Rural Research Alliance of Community Pharmacies, please don't hesitate to let me know, and I will go ahead and put my email address into the chat. And so if you are interested in any of the opportunities that we just discussed, please don't hesitate to reach out. I also do a lot of work, as Scott said at the beginning of our talk, around helping pharmacies to leverage the work that they're doing and expand it to provide the best possible care to their patient population. So I'm always happy to consult in that way as well. I think we have a couple of minutes left, or if there are any other questions. I think I saw one in the chat.
Mark has posted in the chat that with COVID pandemic upon us and the excellence of pharmacy at Ole Miss, how are graduates who are in small pharmacies in Mississippi and throughout the South handling the need for injections that have overwhelmed?
I would be very curious to know how folks are managing that, because I know that we have seen an explosion of desire and drive to get the vaccines from the people of our state, which is fantastic news, but also managing that in the confines of small rural settings is really tricky. And I know we have some community pharmacists, on the line, so I'd welcome any of them to jump in and share their experience as well.
I'll just go ahead and add to that as it relates to our graduates in small pharmacies in Mississippi and the South handling COVID injections, there has been a great opportunity through our CPESN, so our Community Pharmacy Enhanced Services Network, which is a national effort. There's the CPESN USA, but we do have a Mississippi chapter, and the I don't know if Dr. Ballou is on here, but we have been working really hard to ensure that our pharmacies who are in the network have the opportunity and ability to receive the vaccine and provide them. A lot of the pharmacies that are a part of our CPESN are independent small town pharmacies, some in more rural areas, but also in our urban areas as well. And so that's presented a real opportunity for us to engage with patients. The CPESN is really focused on leveraging the clinical services and opportunities that exist in pharmacies and leveraging our work to insurance companies so we can ensure that we're being paid for the work that's provided. And so vaccinations has been a part of that. Pharmacists have done a lot in the vaccination space. And so being able to provide these vaccines in pharmacies is something that's happening. I can't speak specifically to our graduates, but a lot of them are not necessarily new grads, but certainly graduates of our program who are providing these services in pharmacies. I know last week our one of our CPESN partners received their vaccines and they were out in hours, booking people in and getting them in and vaccinated quickly. And our pharmacy faculty have also been a part of that. And that's been really exciting to see, as well as our students, have been participating with that as well. So thank you for that question, Mark.
Yeah, and Sue asked, given your work in population health in Mississippi, what are the top priorities? Where should we be progressing towards in the next 5 years?
And I feel like there's so many. and I think as I don't know if it's an academician space or a pharmacist space, we want to do it all, right? We want to fix all of our patients' problems. I'll tell you, particularly in the work that I've done here in the gateway to the Delta, as Yazoo City is known, I really enjoy talking. We've recently started a weight management program, and so we talked a little bit about the rates of obesity and just how that affects all the cardiovascular or cardiometabolic issues that we see in Mississippians. So there is a collective. It's called the Mississippi Obesity Collective, a recent start by I believe he is an exercise physiologist by training, but really working toward leveraging our interprofessional colleagues, just trying to work between multiple levels of professionals, healthcare, exercise, nutrition, and trying to target, I think, the obesity epidemic, because I do believe that that's what it is. And specifically, it's probably in crisis mode here in Mississippi, because the reversing of obesity can change so many other things. So not only focusing on the individual, but looking at our population and our communities and providing opportunities for people to have the resources to be able to change, that for themselves. I think our patients want to do it, but having the access and ability to be able to do it. For example, there's only one gym here in Yazoo City, and its membership fee is, I believe, around $40. And for our patients who can't afford to pay for their medicines, that's just not something that they can afford to be a part of. So just trying to leverage, I think, some work around obesity and also in implementing policies to ensure that patients have what they need to be their best selves. That's where I would start. Meagan, do you have a thought?
No, I completely agree. As somebody who spends a lot of my time working in with folks who have obesity, I think the thing I would also add to that around kind of accessibility, I've been doing a lot of work in the last little while around access to food and access to nutritious food. And so I think that goes hand in hand with what you're talking about around managing the obesity epidemic in a different kind of way. It's one thing to tell folks, hey, you need to eat more fruits and vegetables. And it's a completely different thing to actually be able to have access to fresh fruits and vegetables that are affordable and manageable for families who are struggling, like you said, to pay for medicine or keep the electricity on or send kids to school with full bellies. All of those kinds of things are really important, and we need to consider and work on them kind of all at the same time, which makes the problem so much more complicated than it might otherwise be. But that piece of it is what I would add.
I think we have come up on our time, and I first want to thank Dr. Brown and Dr. Rosenthal. Uh, your work is very important. Your research is very important, especially here in the state of Mississippi. So thank you guys for not only the work that you're doing, but then taking time out of your busy days to talk to us about this as well. I'd like to thank everyone who signed in and attended today. I hope you got as much out of this as I did. Sarah Campbell is in the background. She runs our Zoom meetings when we're dealing with our schools of pharmacy, and I couldn't do this without her. So thank you, Sarah. And Whitney Tarpey with the School of Pharmacy. Whitney helps us get the word out, and she helps us promote these. So thank you guys for helping me with these events as well. The next event that we're going to have that features experts from our School of Pharmacy is going to be on Earth Day. That's April the 22nd. This is going to be a panel of expert biomolecular scientists from within the school. They're going to be talking about toxicology. And I can tell you, I did a reunion for a graduate group from the 60s a few years ago, and most all of them went on to become toxicologists working like in crime labs. So that part of it was the stories they had were extremely interesting. So I hope that you guys will join us to hear from this group. We will be sending out some invitations soon. So sign up and join us. Again, it's going to be on Earth Day, April the 22nd. And again, Megan and Megan, you were both wonderful today. Great information. And I hope you'll join us for another topic sometime soon.
Thank you, Scott. And thanks everybody for joining.
Thank you, everybody.
Thanks everybody for joining us. Have a wonderful rest of your week, and we hope to see you soon.